and seven funded MLP initiative, six MLP trials. One of them was terminated as a result of the gender ideology executive orders, but still I'm going to walk through that initiative and then wrap it up with future directions and next steps. Um, so how it all started, it actually started back when I was in law school and my work on MLPs, working at the Migrant Farm Worker Law Center, being an intern there in Indianapolis, Indiana, and also Casa Mateo, a safety net clinic for immigrant Latinos living with HIV. And these are some of the qualitative work that we capture back then, right? Many people will go out and seek out services because they're afraid it will affect their immigration status, for fear of being found out as undocumented immigrants. They don't go and seek help. As trans individuals, we're constantly challenged by discrimination and stigma, violence, homelessness, and lack of comprehensive trans care. Support is needed to navigate through legal and medical systems like name change and access to hormones and affirming surgery. Another participant further expanded on the role of the stigma among healthcare providers. When I changed my name, a nurse insisted on calling me he, when that made me uncomfortable. I consider myself a woman. So it was the exposure to these real lived experiences and thinking that it's more about these upstream factors and the social and structural conditions driving the HIV epidemic among these key populations. I'm going to now change a little bit, and we're going to be talking a lot about health harming legal needs. So I just want to have a clear definition of what is a health harming legal need. Health harming legal need is a conflict between an individual and government or private entity, or a deprivation of a civil or legal right that directly or indirectly affects a person's access to or retention in healthcare. Here is some of our works that have pretty much established that MLPs offer structural integrated intervention that could facilitate improvement in medical and psychosocial outcomes among systematically and structurally excluded population through legal aid, and that's the key piece. MLP can ensure that patients are able to access comprehensive service in a culturally sensitive environment. Here's some of our work. Our work on MLPs document the importance of identifying the level of severity of health harming legal needs and risk, initiating action to resolve legal issues early on in that patient engagement process. So thinking more about preventive legal aid, right? Identify those issues before you have an actual eviction. Coordinating with medical and social services support providers to support the patient throughout the resolution process. In particular, that sharing of information and protocols between the legal provider, medical, and social service provider, and having clear communication protocols is key for the success of MLPs. We have also identified 4 core components of medical legal partnerships. You need that champion leader, right? That executive director support of that leadership. The provider and patient trust within the healthcare setting, the physical presence of attorney on site. There are different variations of MLPs, right? There's the referral model, warm handoff to the offsite attorney. But what we have found that a key success, effectiveness of an MLP is having that attorney on site, where patients get a screen for health harming legal need as part of that care engagement process. And if there's any particular health harming legal need identified, they get connected right away there with the doctor on site. And of course, reliable funding streams, right? Attorneys are the cost for the attorney in Philadelphia that we have 1 day a week is $90,000 a year, right? And that entails paralegal. So we do get support from a paralegal and support from the community legal aid organization as a whole, right? So those are the benefits of working with a community legal organization. Studies also show that MLP service reduce healthcare spendings on high-need, high-cost patients, and MLPs have been shown to save patient healthcare costs and recover cash benefits. So I'm going to walk you now through, once again, 7 MLP initiatives. Some of them have ended, some of them have been terminated, some of them are ongoing. Trials on MLPs, and some of them are pending NIH study section review. The first study it was led by Shannon, Wayne, and Emily, and I'm part of that initiative. We conducted 20 key informant interviews with providers in HIV/AIDS service organizations that had some form of MLPs in San Francisco, Alameda, and Fresno. Interviews lasted between 60 and 90 minutes, and teams were inductively and deductively established based on interview guides. To note is that we selected these 20 key informants because these sites, these MLPs, focus and serve living with HIV. So we had a target population for this particular study. What we found was a high demand for legal services for immigrants living with HIV, establishing citizenship, the N-400 application, applying for asylum, understanding the benefits and implications of public charge. There was a lot of fear about the public charge rules and implications for HIV care. Best practices to patient needs, harnessing legal expertise for clinic training and protocols. There was a high demand for training of medical providers, medical professionals, nurses, and social service providers on the implications of these state and federal laws and impact on HIV care. So the idea of training and support for that medical and clinical staff. The need to screen and support patients with legal needs. Once again, train providers to issue a spot. What is a health harming legal need? What would trigger like that initial consultation with an attorney? All of these sites had what we traditionally call the paper screening, right? So there was a form. But ideally, what we also found that there are some MLPs that are more advanced and providers already trained and supported to identify these health harming legal needs without even having an actual screening instrument on tool. So I'm going to talk a little bit more about those best practices later on. Here are some of the qualitative work that emerged. When I first started as a physician, I didn't really know what to write in an asylum letter for the lawyer. There are no guidelines. And actually what helped me was one of the providers that shared a letter that she wrote for a patient. So highlights the need for that training and support within this MLPs for effectively serving patient population. What we're proposing is that there may be a more consistent manner of a screening through the department, through all the clinics, because you wouldn't want anyone to fall through the cracks, right? So the whole idea of having clear protocols on how to screen for these legal needs. And later on, I'm going to show you some example of those screenings. Some of our case managers will walk the person to the lawyer's office. The experience changes when the work is client-centered and non-judgmental. Something that really has come clear around our work is the importance of a presence of a peer navigator that is really well equipped to conduct this screening for health harming legal need for the many reasons we know, right? They share the lived experience, they're connected to the population, they get it. So this is also essential in MLPs. So I'm going to first start with the first study that we just ended. It was an R34 in Philadelphia, and I'm going to share data that I haven't shared before. So it's a new, fresh data since we just completed data collection. So you're going to get a peek of that exciting data. So this was, once again, an R34 that we conducted in Philadelphia in 2 sites, Newlands with Dr. Kwagwa. You're all familiar with her. And TPAC, the Philadelphia AIDS Consortium. So 2 sites, we selected 2 comparable sites based on their patient population, HIV patient population. One of them was randomized to the MLP, Medical Legal Partnership, the other one to the standard of care. And we enrolled 202 participants. We proposed that one of them were going to be randomized to the MLP and the other one to the standard of care. The sites were randomized to MLP and standard of care, and then 100 patient populations living with HIV were recruited from the MLP side and 100 from the standard of care side. Before we launched the trial, we had a comprehensive training that was developed by a scientific advisory board and a community advisory board formed by people living with HIV. And here's some of the content of that training, medical social service providers are not aware of what is public interest law, group, what are health harming legal needs. So we had a robust training on public interest law groups. Lawyers don't know about the HIV Care Continua. So we had a comprehensive session about that. There was a 3 days training that occurred at TPAC, which was randomized to be the MLP site. We also cover screening, best practices for screening. We work with National Center for Legal Partners. They came in and provided training with Medical Legal Partnership Boston. It's another policy institute in Boston that focuses on strengthening the science of MLP. So we had them also come in and provide training. So there was a 3 days robust training, and we did a pre and post assessment on that. Here's the screening that we implemented at TPAC in Philadelphia and Newlands. So the screening was the same in both sites. It is screened for social and legal needs, child support, separation of the board, employment, personal planning, advanced care planning. You will see that was the top health harming legal needs identified among people living a power of eviction or threat of losing a home, unsafe housing or repair. So we had a very comprehensive screening for health harming legal. And of course, we had the option of others for folks to share. So what was on the ground, right? At TPAC, we had one peer navigator, and at Newlands, we had one peer navigator that they conducted the screening for health harming legal needs. So they were connected to the community and did that initial intake for legal needs. Then for those at TPAC, if you screen for one of those legal needs, you were automatically scheduled to meet with attorney from Legal Clinic for the Disabled. They're amazing. Teresa Brabson, Andrew Maud. They have been fantastic on this project. And because we secure a new R01, they will continue. We were able to continue the MLP at TPAC. So we are very excited about that. And then the attorney performed the 30 minutes intake based on that legal case. He could take on that case or do a warm handoff a referral to more specialized legal aid. The good thing about Andrew Maud is that he's a legal generalist, so he can see a wide range of legal issues. And then, of course, we had the study performance assessment, baseline 3 and 6 month follow-up assessment. Here's the sample size. Once again, 202 participants in both sites. We had a diverse sample in terms of gender expression. Most of them self-identified as cis men, but we also had trans women, 13% of the sample. Regarding race, and as you're aware, we nailed it there. We really captured the patient demographic of people living with HIV in Philadelphia. Most of them is concentrated among Black and African Americans. Also, we engage Latino, mainly Puerto Ricans, which really speaks about the patient demographic population of people living with HIV in Philadelphia. So we were really proud about that in terms of really reaching folks that really need it and where the epidemic is concentrated in Philly. In relation to sexual orientation, we had a diverse sample as well. Most of them self-identify as straight, but we also had a substantial sample, 21% self-identify as gay or lesbian, and 15% bisexual. We just published a paper really looking and understanding the level of severity of health harming legal needs. This particular paper just focused on that initial baseline assessment of legal needs. As discussed, personal planning and advanced care planning was the #1 top health harming legal needs. Healthcare, financial power of attorney, how to write a living will. There was a lot of fear, what happened when I die, and what happened during those last hours, of my life. So that emerged as a #1 top health harming legal needs, followed by other concerns. Unsafe housing and eviction or threat, that was another top health harming legal need that was impacting people living with HIV. We also we dived into the attorney case summary. What was happening within that lawyer-patient interaction and how these legal issues were tackled and addressed. So we capture the needs, the case summary, comprehensive case summary that the attorney provided, the outcome resolution, what happened based on that patient interaction, the perceived benefit of the legal intervention on the patient, and of course, outstanding issues that were not being able to address with this legal intervention. So the paper really dived into both that initial baseline assessment, but also on what happened with that patient-attorney interaction. The study identified a wide range of legal services provided to people living with HIV, which either were mitigated or fully resolved through the MLP, and that's what I called here the Andrew, the attorney, and the Sandy effect, the peer navigator, Andrew, Sandy effect. Findings help the field to better appreciate the complex relationship between population level social drivers, individual level health related needs, and health harming legal needs that impact people living with HIV. We went further, and this is now under review. We just once again finished analysis. We conducted Kaplan-Meier survival analysis and logistic regression to assess the time to viral suppression and the likelihood of achieving an undetectable viral load at 3 and 6 month follow-up. Participants in the MLP sites achieved undetectable viral load at faster than those to the standard of care condition. At 3 month follow-up, MLP participants were significantly more likely to achieve viral suppression. Although at 6 months, the odds ratios were reduced, it did not reach a statistical significance. But there were several factors because of that, the small sample size that we had. But we're really, really excited about the findings and the promise of this MLP approach. Up to now, if you look at the literature on MLPs, a lot has been done on the effectiveness of MLPs on addressing legal needs, of identifying legal needs. There's a lot of literature out there on the impact of MLPs on policy and advocacy, but there's limited data on actual health outcomes, right? And here's building on that evidence that we were able to prove that a legal intervention, right, coupled with a peer navigator may have actually implications on critical HIV care continuum outcomes like viral load suppression. So the next logical steps, we're working hard. September submission to either a private or NIH grant to really test the effectiveness of this medical legal partnership approach in New York City, Philadelphia, Orlando, and San Juan, a hybrid type 2 effectiveness trial with power HIV care continuum outcomes across all these sites. And we're building on the same concept. We're going in at HIV/AIDS service organizations. So we're intervening within community service organizations that provide comprehensive wraparound service for people living with HIV. We also, we're in the writing mode now. We have another paper looking at the qualitative data from the patients, right? How the patient saw that interaction with the lawyer. So we saw in the other paper more of that lawyer perception, but we wanted to see how the patients interacted and felt about that legal component of the intervention. 6 themes were identified: empowerment and knowledge building. Participants reported greater confidence and understanding of their rights. Trust, respect, and cultural competence. Participants felt seen and valued through inclusive, respectful interaction. Accessibility and integration of legal aid. Embedding legal services with the HIV care was seen as essential and long overdue. The whole idea of really strengthening these wraparound services. Legal advocacy and practical resolution, right? Many receive concrete assistance with benefits, name change, legal planning, and advanced care planning. I just wanted to know too, one of the success of this is that the 17, so we had 17 individuals who self-identify as transgender, and they were part of the legal name change clinics that we had. We had 2 clinics for related to legal name change. There was also this theme about relief, emotional support, and therapeutic. Participants highlight the emotional benefits of being heard and supported by an attorney, right? And it's important to understand that there's a critical conflicts and issues, right, of people living with HIV, underserved community, and the criminal justice system, and lawyers. So they felt supported through this process and interaction with the lawyers. So Aka, the Andrew effect. There was also limitations in legal score of expertise. One of the challenges, I'm a big fan of working with community legal service. So for this trial, we work with Legal Clinic for the Disabled in Philadelphia. And because of their funding restrictions, they cannot see criminal law or immigration cases. So we had to do the warm-off referral to those cases. So there were limitations on the things that we could see as part of this that we could address of these trials, the complex legal needs and of course delayed in access. Here's a snapshot of some of this. Still good on time, good. A snapshot of some of these legal clinics that we conducted in Philly: family law overview, tenants' rights, transgender, legal name change, and of course advanced planning. Here's some of the voices from participants. Muy interesante para aprender sobre los derechos que tenemos y empoderarnos con la información, going back to that idea of empowerment as a resilience tool for participants. The sessions about eviction prevention and eviction law in Philadelphia are very important. This is a great need for people to understand the process and be more engaged with housing counselor, law project, and fair housing community. Let me see if there's any comment. I believe that there's one. Perfect, just about questions, okay? So the second one is a project that is currently ongoing. It was a 2 years trial as part of a P30 mechanism. Steve Safran being the PI, and we were just the study PI, Martinez, Nawani, and Prado. We wanted to test this MLP model in Hope and Help, one of the largest FQACs in Central Florida, and the only program, syringe exchange program in Central Florida, House and Hope and Help. So we wanted to test this model with formerly incarcerated individuals living with HIV. Because of the limitations, as you know, of grants from the P30, funding, time, we just opted for pre and post. So we're doing baseline 3 and 6 month follow-up assessment, and there's not randomization of clinics or patients to either to the MLP and the standard of care. The project is currently driven by, is driven by REAIM and CIFR implementation science frameworks. Once again, we worked with a scientific advisory board and community advisory board to develop a comprehensive training for providers prior to the launching of the trial. The difference between social determinants of health and health harming legal needs. What are some of the mental health issues with impacting formerly incarcerated individuals living with HIV? Once again, what is public interest law, right? Many medical and public health professionals are not aware of public interest law and how to put this together, right? Putting this medical legal partnership initiative together. Here's the screening instrument that we have for the current trial. This current trial, criminal record expungement, of course, is the top health harming legal needs impacting people, formerly incarcerated individuals, legal name change. We kept advanced care planning and other social and health harming legal needs. And once again, this was informed by scientific advisory board and community advisory. We didn't use the same instrument as we did in Philadelphia. We just expanded and adapted based on the new patient population. Here's some of the flyers, recruitment that we have put together. We are very active on social media. A big shout out to our team here in Philadelphia. Here's the flyer for the community advisory board that we had together. A little bit more about the scientific advisory board. We have 4 attorneys, 7 academics, and their feedback was critical to inform that training, that initial training we had. They were really concerned about navigating how patients, the challenges of navigating the layers of complicated legal systems. So that was embedded as part of the training as well. And in assessment, they were really concerned and really highlighting the need of capturing immigration concerns among immigrant participants, family concerns, right? Looking at a whole unit of analysis and how legal issues impact not only the patient, but the family as a whole, as well as ensuring that we capture the living conditions impacting formerly incarcerated individuals. We're excited. We're almost halfway through. We have enrolled 46 participants, and our completion date is scheduled for November 2025. So fingers crossed, we're going to get there. The other project is currently ongoing. It's an R1 effectiveness trial. We're testing this MLP model with immigrants and Latinx populations. So it's either Latinx or immigrant communities in New York City, Philadelphia, and San Juan, Puerto Rico. It's a hybrid type 2 effectiveness trial. We're doing baseline 3, 6, 9, and 12 follow-up assessment. And the primary outcome, quality of life, we're using the PROMIS 10 items scale that measure quality of life, physical, and mental health. Here's a little bit more about the study team and the organizational structure of the team. We're working with FQACs or community health centers with a large volume of immigrant or Latinx immigrant populations that provides wraparound services. So in New York City, we're working with Betances clinics. In Philadelphia, we're working with TPAC, so we continue the work there. And in San Juan, Puerto Rico, we're working with Health ProMed, is one of the largest FQACs in the islands with offices across the island of Puerto Rico. We have a legal referral network, and we're working with legal aid organization, Legal Health in New York, Legal Clinic for the Disabled in Philadelphia, and Servicios Legales de Puerto Rico is the largest public interest law groups in Puerto Rico there for providing free legal service for folks. Here's what is on the ground: 2 social support coordinators per site for screening for health, harm, and legal needs, and attorney 2 days a week at the healthcare sites. Before the launch of the trial, we had a training that we did in Puerto Rico. One of the key pieces of this training this time, rather than a top-down training, actually the sites were part of that training and presented. So we had the FQAC's executive present about services provided within the organization, but we also had the legal sites, the legal providers talk about their services. For example, the key challenges in providing legal aid in the territory of Puerto Rico, right? What does it mean to be a colony and providing legal aid in Puerto Rico? Strategies to address some of these health harming legal needs impacting migrants, Haitians, Dominicans. As you're aware, there's a large presence of that in Puerto Rico and implications for legal aid for those communities. And Hadassah, the attorney and executive director of Servicios Legales de Puerto Rico, is a champion and someone I truly, truly admire. Here's a snapshot of the training. This was a 2 days training in Puerto Rico. And here's the entire team. We have an active interactive website for both legal and healthcare sites where they can go in and learn more about what is happening across all the sites, and participants also have a chance to go to the sites. We're very, very excited. We have 318 participants enrolled to date out of 960. We're on track to surpass those recruitment targets. The end date is December 2026. And then, of course, we're going to do data analysis and dissemination and identify next steps. Now, the other project, and I want to commend the PIs. This was part of the ATN Adolescent Trials Network that was terminated. Lisa Hightown Waitman, and Sybil Hosek. We also had, I was part of the ATN 167 protocol, the first one that was terminated. So it was a step process of termination. First, they terminated ATN 167 that focused on trans youth, and then afterwards, they terminated the entire network. Big shout out to the PIs for ATN 167, Christy Gamarel, Reisner, and Jenny Ismail Wilson. I was in charge of that legal component. So we wanted to test a multi-level intervention that included legal, economic, and affirming peer support for transgender youth of color. So it was, once again, 3 components. I was in charge of the legal piece, screening for legal needs, and then linking patients to legal aid across all the sites. And the primary outcome was pretty much HIV prevention and care continuum outcomes. Here's a little bit about more about mediators and outcomes. The three pieces: affirm people, the legal support that entails screening and direct legal aid, and the economic support that entails microgrant for education, economic group sessions, and emergency assistance for the trans youth. We're looking at key mediators, social support, gender affirming care, the reduction of health harming legal needs, increasing economic stabilities, financial support, and future orientation. And once again, this was a status neutral intervention looking at both HIV prevention and care continuum outcomes. Here's the snapshot of the 10 weeks intervention. It was well thought out, comprehensive, driven by a community of a youth advisory board of trans youth that were critical in developing these projects and implementation. Once again, on these three components: behavioral, legal, and economic. Here were the sites for ATN 167, Callum Lord, a champion of gender affirming care for transgender population, Fenway Children National Hospital, Tulane, St. Jude Children Research, Children's Hospital of LA, and University of Illinois. Critically to this, we were going to launch on Monday, and on Friday we got the termination. We had this 7 sites. Out of the 7, 5 we pretty much had service agreement established with 5 legal organizations. As you can imagine, that took a lot of time and negotiation. So we were going to have 5 sites with the typical MLP approach, with attorney on site serving transgender youth and their families. And 2, we're going to follow the warm handoff referral to legal aid, but also entail coordination with that legal side to ensure that there was a real warm handoff referral. In the process of implementation, even during the Biden years, we were really mindful of the anti-trans legislation. So ensuring that we had a robust protocol, really mindful of those state laws. We were also really mindful of working and really putting together a comprehensive health harming legal needs that was once again developed by trans youth, and also on data, right? Working with the other sites and the other ATN protocols to ensure that there was data harmonization across all sites, and the instrument that we're using were being implemented across all sites. We appealed, fingers crossed, but I felt like it's important to share what we learned, processes of these terminated grants, because it's part of that dissemination, it's part of that learning process. I'm happy to discuss, to have a follow-up on the discussion section. In a way, as a professional, I'm glad it got terminated prior to enrollment, because I will argue, if we will have enrolled participants, can you imagine the harm that we will have caused for those who are already enrolled, and the impact of that termination? I mean, I have been digging on the implications, right? Ethical implications of adverse events resulting from this termination for those trials that have already enrolled participants, how to do it ethically and legally, and ensuring that we don't harm, that we don't further traumatize these populations that are in constant attack. So in a way, and once again, we can have more of that discussion, I'm actually glad that they terminated it on Friday before we launch on Monday, because the harm will have been even more, I will argue, for those participants that were enrolled, and then we'll have to terminate them, this enrollment from the trial. This one is another proposal that we submitted last year. It got an impact score of 24. We put together a strong, robust R1 effectiveness trial to really roll out MLPs across several sites in the island of Puerto Rico, supporting sexual and gender minorities. We put together the memo back in November, but this is not going to get funded. It includes sexual and gender minority population. It's clearly that this doesn't align with NIH priorities. We're going to repackage these to a new funding and grant mechanism. Here's an example of the site that we're going to be diving in and tapping for this MLP trial. Here's the snapshot of what was going to entail in 1, in 2, and in 3. Critically, once again, Reem and Siffer frameworks, like some of the constructs that were captured, like what is happening within the outer setting, inner setting. Here we use the community resistant frameworks, and I commend Carlos Rodriguez Diaz and Suhel Malaver Rivera, who have been pioneering this framework. Is homegrown framework from Puerto Rico after 20 years of experience of their work in the island that really take into consideration the experience of colonialism and colonization on access to care and research for vulnerable populations in the island. The next project is pending a study section review. It's a mobile medical legal partnership initiative here in Orlando to address housing instability. So we will see. Is these slides we were really upfront and really highlighting who's disproportionately impacted by homelessness. Transgender individuals, elderly, veterans, right? So it's all in the proposal. So who knows? Here's more about the intervention. It was a three arms intervention, three arms study: peer navigation alone, mobile health unit plus legal aid. So it's the mobile medical legal partnership where the attorney is going to be in the legal units. We have three different, we operationalize three different sites, and then the interventions were going to be delivered within these three sites. Community-based centers, service centers serving homeless and unhoused individuals, shelter-based settings serving unhoused individuals, and then high-need community locations in Central Florida. Dissemination and implementation is a key component of what I do and what we do. So here's in three more about the processes for designing for sustainability, having sustainability in mind. I'm happy to talk a little bit more about that in three later on. Future direction moving forward. I think I'm still on time, have 3 minutes left, so we're good. I'm a big fan of Dr. Buleg, Lisa Buleg, thinking about intersection structures, looking at upstream factors and the need to intervene there, structural stigma, racism and discrimination, housing instability, expand robust medical legal partnership, community research collaboration, defined and guided by recognition that community development is an important focus of research, commitment to build upon the strength and resources of individuals and communities, promotion of a process that actively addresses social inequities, and dissemination of findings and knowledge to all partners. Here is something that we're cooking and is kind of the next steps in our continued work on medical legal partnership. Wanted to highlight here the work of Samantha Morton that really has pioneered and has coined this concept of team-facing legal support. So you have patient-facing legal support on one side, but what happened to providers? What happened to that MD, nurse practitioner, peer navigator, social worker within that clinical setting, right? There's the need to increase capacity building for staff on sound detection of health harming legal needs, providing high dose orientation and training to staff, right? The legal epidemiology field is rapidly changing, right? City, state, and federal policies are changing, right? What are the implications of this health law policies on patient populations, on providers? The perfect example is on gender affirming care. And in Florida, with the bill that passed in the Senate, providers were scrambling what to do, how to comply with these state laws. So that is highly needed within these healthcare settings, that team-facing legal support, providing continuous practice, allowing learning strategies, producing ongoing legal informed problem solving and skill building for cross-sector colleagues. Here's a snapshot of also the next future direction for MLPs. This is coming from the National Center of MLPs. On a screening and referral, what do we need to be thinking about, right? The number of patients screened, the number of referrals made. On legal service provider, the money valued of legal service provided, right? The number of patients successfully connected with the MLP team, the type of legal issues of which curbside consultations were requested, and then outcomes is that money value of benefits obtained for patients, the money they recover for health center through successful appeals of health insurance denial, right? So what is the benefit of having an attorney on side on that cost for the healthcare organization and for the patient satisfaction, and of perceptions of stress and well-being as measured by survey. This is my last slide, so we're good on time. Across our work on MLPs, community health worker peer navigators are the forefront of this model. They have the connections, they have the trust with the community, and they have served as key components of our design for these trials and our implementation of these trials. I want to thank our study participants, my mentors from Dr. Fernandez to Dr. Sonia Arriola, our team here at University of Central Florida, the Implementation Science Research Lab, and all of our healthcare and legal partners. And with that, I think we're good on time and we have a few minutes for Q&A. Thank you.
Amazing, Dr. Martinez. Thank you so much. And we have actually two comments in the chat. I'm going to start with that. And if any of you have a question, please raise your hand. And if I can see you, you can interrupt. No issues there. So actually, there's a comment from Corey saying, would love to partner with you if you ever want to expand in Houston. So Corey, I don't know if you are able to speak and elaborate on that a little bit more.
Yeah, what is happening in Houston, Corey? Tell me
Oh
more.
my gosh. A lot of the same things. Yeah, I mean, I'm sort of new at the University of Houston, just moved to Houston from Memphis. But we have a medical legal partnership and are facing a lot of the same challenges. And I'm in the medical school and happy to, I don't know, I would love to
Yeah.
work with you, introduce you to the people that would love to work with you over here.
Thank you. I will definitely follow up. So a little bit more about the MLP that you have. So you have an attorney on site. Is it a legal generalist? Do they hire that attorney internally, or is it part of a community legal organization?
So we actually were like a full university here. So we have a whole legal program, a law school as part of the university.
That's excellent. And that's another model I forgot to mention. I'm a big fan of the community legal service model for several reasons. I mean, you're partnering with a safety net legal aid organization that is staffed with paralegal, with legal generalists. So you have that support, that institutional capacity support when you have that partner. I'm a big fan also partnering with the law school clinics. For example, they have immigrant health, health law clinics, right? Family law clinics. So you see a lot of that model too. Healthcare organizations partnering with law school clinics. The challenges is that, law school students during the summer, peace out. They're doing their internship at top law firms or at other, organizations, right? It's part of their, 1L and 2L and 3L. And then you have that gap. You tend to have that gap. And faculties, like, you know what I mean? On vacation. So you have a little bit of that gap during the summer and less of that sustainability, but it's still another great model that is cost effective too, right? You get,
It's interesting.
free legal aid. You don't have to pay for the $90K that we're paying in Philly.
And we are just really quickly, our medical school is a little bit of a different model too. It's very community focused. So,
Which is, yeah, that makes sense too of having an MLP there.
yeah.
Excellent. Thank you.
Great. And Corey, if you can put your email in the chat, that way Omar will have, your information and you guys can communicate.
I will. Thank you.
Thank you. And Amanda, I'll turn it over to you for your comment.
Yeah, thanks, Dr. Martinez. Really interesting presentation. And I am a peds critical care clinical person, so I really hadn't thought about this type of partnership. And you had some really interesting findings. So thank you for sharing. I really learned a lot, and I'm sorry to hear that the project that looked really great and wonderful is not going to progress. But my comment is about this idea of the long-term
Yeah.
implications of folks who were enrolled in research
Yeah.
projects that have been terminated. And lately, and of course, they're not going to sign up for the next one, and there are all kinds of ethical implications there. Lately, in my world, I've
Yeah.
been thinking about designing for implementation in the clinical world where clinicians would hate to do the thing that we're going to ask them to do in a clinical trial. And so we're using implementation science to design the protocol so the clinicians won't hate it and we can actually
Yeah.
execute the trial. And now you talked designing for dissemination, but I was wondering if you have any thoughts about designing or for implementation or enrollment, like some sort of way to get folks to like be willing to play ball again if they were in a study that's been canceled or if they've experienced these sort of adverse effects of abrupt funding termination, for example. Just
Yeah.
wondering if you had thoughts on that.
Yeah, so there's definitely a lot going on there. Thank you for your comment and questions. I've been thinking a lot, and we haven't had to, right? We have for the ATN 167, we were not enrolling yet. So we didn't have to deal with that. But you nailed it. There's also the implications of trust. These participants' future enrollment of trials, their harm resulting from that, the trust of enrolling in a trial, given the implications of this, emotional issues that may result, distress that may result from disengagement participants, their harm itself on health, right? So I mean, there's some biobehavioral interventions that are occurring, biobehavioral tool, like biomedical, right? Biobehavioral interventions that are happening that include a biomedical tool. What does it mean, right? That you're discontinuing an intervention and stopping that intervention on that psychosocial impact and on health of a study participant. So there's a lot there happening. Regarding designing, I mean, is one of my favorite, designing for dissemination and sustainability. I just wanted to share really quick. I mean, it's something that we worked on, so why not sharing? It may not get funded, so it's all about sharing, right? Let me see really quick, because I scanned through that slide really quickly. And one of the key things that, right, we started to thinking is identifying the partners, right? Who are going to be potentially these implementers and these champions within the clinic. So identifying those implementers, potential implementers for sustainability, the buy-in of those or not buy-in, and why. Engaging, emphasize and outline the problem, coming in clearly. You clearly have identified a problem, understanding the context, the policy context at the clinic, their mission, their vision, the whole idea of co-designing, ensuring that whatever intervention it is or whatever program it is, co-design and with those potential that folks that are going to implement it, whether it's peer navigator, whether it's the executive director of that clinic, having their buy-in and having them co-design the intervention, have a clear dissemination plan. Ensure that if you have a community advisory board, they're part of that dissemination piece, and then have a component with implementation science, as we all know, have that iterative evaluation throughout the intervention implementation, so that way you do those changes based on that evaluation of the intervention, and of course planning for sustainability, the cost, and so forth.
Yeah, I think that co-creation piece is like the key always to that stuff in my view. And we might need to start it sooner, maybe in the design of our research, because that trust may be lost for some individuals that have been kind of burned by some recent events.
Yeah.
But great, really interesting. Thanks so much.
Thank you, Amanda.
And actually, I have a question, but if others have questions, please raise your hand or you could unmute. So my question, Dr. Martinez, has to do with finding the right set of legal experts, right? Because I guess for us in healthcare, like there's such, I mean, our field is very siloed, right? And as you mentioned, there's a lot of mistrust with patients. So
Yeah.
finding the right set of partners is really important because if the patients go and they encounter stigma at the legal experts level, and obviously for you, you spent a lot of time training, which is amazing. But like, where do you find those legal experts?
Yeah.
And it feels like they're embedded already in the community.
Yeah. So in law, we have what we call legal generalist. And I scanned through that really quick, like in less than a second, typical Omar. But legal generalists can see a wide range of legal issues from family law to immigration law, right, to crim law, right? So they're quick to address this wide range of legal issues. And usually a legal generalist housed at a community legal aid organizations like Legal Clinic for the Disabled in Philadelphia, AIDS Law Project of Pennsylvania with Rhonda Goldfein, right? So they can see a wide range of legal issues versus those in private practice that they specialize in patent, health law, family law, immigration, right? If you go to an immigration lawyer, they may not be able to address, right, a tax law issues or, right, or corporate law. So I tend to, with this MLPs, with this key population that are harmed and encountering a wide range of syndemics and health and legal issues, I tend to partner with those community legal service. For example, in New York, Health Law, another public interest law group, with Randy, champion attorney for the 80s that started during the HIV epidemics, right? So she's the executive director, and then she has built this great community legal service organization that over 100 attorneys and hundreds of paralegals, right? That they're all legal generalists, right? Once again, they can see a wide range of legal issues. Same as Servicios Legales in Puerto Rico is a large, public interest law group. So you partner with community legal service with a large number of legal generalists and think about, do they have paralegals? What is the other support that the attorney gets from that community legal service organization? But you nailed it. Although another key success, so Legal Clinic for the Disabled, because of their trust in Philly, they have all these pro bono attorneys, corporate lawyers that want to feel good, right, and have the resources, and they partner with those, and the more complex immigration and criminal law cases, those pro bono attorney take on. So we have used that model with Legal Clinic for the Disabled because Andrew is a solo show, and the community legal service organization is a strain. They have a lot of cases. So we have been able to outsource some of that demand with these pro bono attorneys that are also part of the MLP, and I'm thankful to them, right? Like, I'm glad that they're feeling guilty, that they're making, you know what I mean, the big money, and they're coming back to do some good and some legal justice work. So we just actually had a clinic at TPAC on immigration laws. Philly, patient population, immigrants are just, there's a lot of fear happening. So we had just had a big clinic, and then all of them were big shot immigration lawyers from Pennsylvania, with big law firms coming in and taking on these cases on immigration law. And it was because of Legal Clinic for the Disabled connection. So there's also that piece that is important to highlight, and I'm grateful for the big shot attorneys making the big money.
Well, thank you so much. We are at the hour. Actually, Stefan had to step out, but he left a nice comment, and you have other nice comments coming your way.
Appreciate it. Thank you.
But thank you so much, Dr. Martinez, for speaking about this expertise that I feel like is more and more valuable, particularly these days. And we were really excited to have you as speaker.
Likewise, good to see you all. And Cody, I will follow up. We need to bring in and work on MLPs in Houston. maybe you're going to be part of that next trial, the multi-site. It's not Houston. Thank you.
All right. Take care,
Bye.
everyone. Bye.
Bye.